All right. So my name is Amy Corneli. I'm in faculty in the Department of Population Health Sciences. So I'm a social scientist by training. I work with CFAR. So I'm the director of the Social Behavioral Core, and so I'm asked to come in to talk about something very different, really, than some of the other projects that you've been on, and focus on community partnerships and some projects that really try to blend community partnerships within art with science. And so you'll see what I mean as I go through all this. So let's see if this is going to move.
Maybe you do have to keep it.
Maybe. Yep. Okay, so we'll talk about two things really. I'll go over some partnership models that are out there that we try to follow when working with communities. The big push really in HIV research and other places, but particularly in HIV research, really is for academics to partner with communities. And it's a wonderful partnership because you have community groups, and community can be defined in many different ways. They know what's going on with people who they are there to serve. You have a community group, their focus is to improve the lives of somebody, in this case, people who have HIV, or they're there to help people prevent HIV. They know what's going on the ground, right? And that's their whole purpose, is to improve lives. And as researchers, that's our whole goal as well, far removed, right? So we're here in these offices in front of computers most of the time. But the partnership needs us too, right? So we're able to get a lot of funding, more so than community groups, and then we're able to find out if the programs that we implement actually work. So that's why you have these nice partnerships with communities who they know what they're really doing in terms of what's going on the ground, what's needed on the ground, and then we bring in those methods in terms of, here, let's figure out how to evaluate and we can get the money. And so there's models out there to follow to help us do that. And then there's a whole spectrum of how you can engage the community, to where they are complete partners with you in decision making, versus you kind of come to them every once in a while for feedback. And so that's what I'll go over with you. And then I'll talk about two examples from my work about some HIV research that I do with a range of partners. Okay, so here's the model. So this was created focusing on patient groups. So there's a lot of groups out there, you've heard of them, where there's an organization that supports patients. The American Cancer Society, lupus organizations, they're all out there where they are advocates for patient groups or patients with a certain condition. And this was created to help patients figure out how they can engage more with researchers. So it's quite nice in terms of looking at all the different ways that you can be involved. I'm going to grab my mouse so I can use that. But you can see on the top, there is all the way to the left, is engagement, but it's very minimal, to all you have over here, all the way to over here. Oh, you can't see my mouse. All right, well, never mind. Let me see when I do this. Oh, no, you can do it now. Great, okay. So you have all the way over here where you have pretty, not that much engagement community, to over here where you are really joining them. So we're going to go through each one of these. So you have this one, the most common method that people do in HIV-related research is you consult the community. And you do that through social science means of conducting what we call formative research. You go and you do interviews with potential participants, other people that are key collaborators, and then you use that information to help inform whatever you're trying to do. And so that's consulting. Involving is another way that academics partner with communities, and that's your community advisory board, where you'll have a whole bunch of people from the community that somehow get connected to this board. You go to them as a scientist, you present your information, they give you feedback on it. So these are really the most common ways. As you can tell, they're one-offs, right? So do some interviews, they give you feedback. You know, the community advisory board, you go to them and they give you feedback. It's kind of this one-off thing. The most engaged is in lead and support, where you have these community groups that really want to be a leader in research as well. That's not very common, but that typically comes from patient organizations. There's OI foundations. Some foundations create a registry where they collect data from people with whatever condition it is to be able to have a nice registry of people's symptoms, or a whole bunch of data that they could like that researchers can use. This really isn't possible for most community organizations. So this is really what we're trying to push people to do, and what I try to do are these more meaningful record methods where you're collaborating. So you collaborate equally. Everybody's at the table, as I mentioned earlier, bringing things that are important that you need both to have a good product at the end. You both agree on the overall goal. You want to improve people's lives. You're both going different ways to do it, but you need both. So you really do each other very equally. Where you have your community partners, they service the actor, they service the lives. This is really what we want to strive for. And there's lots of different ways to do that well. So what we try to do is involve people very early in the process. What academics get criticized for is lots of times we know we're supposed to engage the community. They have a grant coming up, and then we contact somebody in the community right before the grant's due, and will you be our partner? We get plans for that all the time. And so what we're doing a much better job about now is really have long-term partners. We write lots of grants with. We stay in touch with them in between grants. They really become your friends. They really become your long-term collaborators, your long-term partners. At the beginning of that, you do set and you manage these expectations and these goals. Again, community, they look at what's going on, they bring that, the research part, we bring that, it works really well. Those are the expectations. There's lots of acknowledgments all around in terms of what people do, that we can't do it without both partners. We meet face-to-face a lot. In the face-to-face, this is good when you're in person, but even face-to-face over Zoom. A lot of my partners are not in Durham. So being able to have Zoom really actually helps a lot. I do a lot of work in New Orleans. I do a lot of work in Charlotte. When I do travel up there now, in between I have Zoom. Just having that FaceTime, seeing each other is great. Other big important part is training and education. And what's important with community collaboration is that co-learning. We always think, okay, well, we're the academics, we need to train other people, we need to pass on the education, but it really is both ways. There's so much that we can learn from our community partners. We always want to keep that in mind, that there's this bi-directional communication, bi-directional training. And one of the things that's really, really big is lots of times we want community partners to do things voluntarily. Most of us don't do things voluntarily for our job. Pay, stay, do research. We pay community partners just the same. We never expect anybody to do anything voluntarily. We don't, and you know what I mean. We do things voluntarily in terms of our off time, but our work that we do in HIV research, we get paid, and we always want to compensate people for their time. So now I want to explain two partnerships that I have, two projects that I have. Where we have really great community partners who I have been working with for a very long time and really enjoy what we do. So this first one is called Start the Conversation, and this is in New Orleans. We started this partnership in 2019. We did create a new partnership just for a grant, and so that is very common, where there's a grant opportunity coming. We know we want to work in a certain area because HIV statistics tell us we need to go there because the rates of HIV transmission are high. I work on the intervention, and then we try to find a community. So there was a new funding opportunity coming out in HIV 2019. I have a partner that I work with a lot as a clinician in New Orleans. We knew we wanted to work together in New Orleans, and so we looked to find a community partner and then created a grant that I'll tell you about. And the second one, Local Paro, is in Kenya. I just returned from Kenya on Friday, and that's with young cisgender women. All of this is on PrEP uptake. So the Local Paro is focused on reducing stigma, but both of them are incorporating PrEP into the work that we're doing. So our project is key. Okay, so start the conversation. Again, this focuses on Black cisgender women in New Orleans who are at much greater risk than other women and some men because of the environment we're in. Systemic racism really does impact the ability of people to be able to limit transmission of HIV, and we really do see that in New Orleans. So the funding opportunity I mentioned is, you all probably heard about it, 2019, the U.S. government came out with all this funding called, Ending the HIV Epidemic, the HE Initiative. And so I think there were maybe 200 people that were funded over 5 years, I think, of giving them. So this was the first year Meredith Clement, the PrEP provider, and me were involved in this. And one thing, as you build your career, it's really nice to find people who have complementary skills to you and stay with them. So Meredith Clement, she's a prep provider. She's an MD. So she has, she is a provider prep. She knows all about the clinical aspects of prep. I'm a researcher, a social scientist. You kind of need both to be able to do the work that we do. So we partner together. We have these complementary skills. We both serve as PIs on our grants. We get them funded. It's a great partnership, but we continue to work with each other forever. And that's something that's really nice and you want to look for, because then you have good relationships. You know how each other work. Looks good from a grant point of view. And I always like to see partners continuing to work together because they know you can do something successful. So we received this 1-year HIV ending epidemic grant, and these are basically to build partnerships, gather some initial data. And the whole idea is you go do formative work, you build partnerships, you get data, and then you apply for a larger NIH grant. So that is what we did. Got this informative work, and then we wrote an NIH R34, which we did get funded. So our two main partners with this, the first one is the Black Women in Prep Task Force, who we have been partnering with since 2019, and we're still partnering with them this year up to now. They are a group of, so they're a bigger group, but we have a smaller group that's working with us of 12 influencers, women influencers, Black women influencers in New Orleans, and they have professions across the board in what they do. And I've been out there 3 times this year to meet with them in different meetings to talk about the work that we do. But they helped us really design our work, and I'll tell you more about that. And then we also partnered with a group called IWIS, the Institute for Women and Ethnic Studies, and they helped us develop the materials that I will show you. And then the two academics are Duke and then LSU, where Meredith is. So this is a picture of the larger group of the Black Women in Prep Task Force. And here's just the timeline of the work that we have done. So community partnerships, community grants, long term. So we started in 2019, and said a few times. Right now, it's 2024, we're going to write a grant submitting another grant. We're going to submit in January 2025 that will go for another 5 years. So it's going to be funded. This is a long 15, 20-year relationship that you build. It makes it really, really rewarding because you get to know people on a very personal level. You get to do some really cool stuff with them. So when we were first funded, we did some formative research with Black women on prep. That was led by our community partners. We trained up people from the community to do the interviews. I run a team here at Duke called the Qual Corps, where we have experienced qualitative interviewers and analysts. We didn't want to use them. So sometimes going to the community is better for people that reflect the community. So we trained people there to be able to do the interviews, and then we did the analysis. Then we had lots of meetings here to talk about the findings and think about what do the findings mean. The Black Women in Prep Task Force, they were able to have to really interpret the findings, help us know what's really going on the ground. So we kept meeting and to talk about what do we want this next grant to look like. Here we found these data about what are reasons women want prep, what are the barriers to prep uptake, what are the facilitators of prep uptake, what can a grant look like, all these meetings, and then George Floyd was murdered. And then we had to take a step back. This was something that you all remember, big deal in our society. And we're dealing with Black population in terms of as our talk about, right? Black women. And so we needed to stop and think about our role, what we were trying to do. We then participated in as a group, all these trainings on undoing racism, thinking about how that can be incorporated into our work, and just taking a moment to pause and just life isn't all about. So then after that, we continued with our meetings, and then we identified the interventions we wanted to do. And so these are the two things that came out of our data, and then the women and the Black Women in Prep Task Force said, this is what we really need to focus on. Black women do not see other Black women needing prep, and providers do not offer prep to Black women. So this is what we need to do. So then we had to think about, okay, here are the two goals that we want to be able to do. We want Black women to see other Black women taking prep so then they know it's them, and then we want providers to offer prep. So how can we do that? So we met and we came up with this new grant. It's called Start the Conversation. And the whole, you'll see a logo from it later on. But all these meetings that we had with the Black Women in Prep Task Force, they kept saying we need to start the conversation, start the conversation. That easily became the name of our grant. You'll know that people love to name their grants because listening. given something, you'll use it all the time. So start the conversation is a great name to have. And so the whole idea is practice forming you. So we did lots of things to really get this out. We hired a local artist to create the branding for that. So I'll show on the next slide. We then partnered with Iris, as I mentioned earlier, to help create this social media content. And then we had this woman right here, Catherine Carter, who was a contestant on The Voice. She's a local artist, recording artist. So she created a prep jingle for us. And so what we decided to do is how you can see on these two things right here. For all those meetings, we decided to do two components to address those two things. First is a social media campaign, all these things I just mentioned, which is designed to show Black women that prep is for you too. And then we did this whole GYN training partnership with LSU, OBGYN residents, about training them on historical and cultural context that influences pregnancy among Black women, and train them how to offer prep to their patients. So those are the two approaches that we try to do in order to address the two things that came out of our data and our research and our partnership. And I meant to check, let's see if this is going to work. This is the jingle that was created that we have been playing as part of our campaign. That to kick off our social media campaign. So our social media campaign started in my people trying to party. There we go. We started our social media campaign of March of this year. We are about to finish it up at the end of June. It's a 4-month campaign. We use the formative data to be able to identify a new message for each month, which I'll show you in just a second. But it did start off with this big, to-do of this prep jingle by someone who's a local artist, famous person. Okay, and here's what I mentioned earlier in terms of Amber Ivy, and that's the artist that we worked with in order to create a logo, in order to create our branding. And so all of our materials, all of our training materials are all in these colors and this look in terms of, so when you see it, then you know, oh yeah, it's part of the, start the conversation. And then here just shows you a little bit about the science that goes along with it. This is our study design. So we do have, the LSU site is our main site. We collect data for 4 months prior to the intervention. And then we have what we call the combined care model, which is just really the OBGYNs that are offering prep to their patients. And then we offer the 4-month social media campaign on top of providers offering prep. And so we see, we compare this, how many people go on prep or talk to their providers about prep to this pre-intervention period. And then we look again, how much of the social media campaign increased conversations about prep here or here. And then we have a comparator site where we look at the number of conversations they had for prep uptake at Tulane. And so these are just pictures of what our prep training looks like. So here's in this lower column are all the prep residents that we trained. So there are, I think, around 15 or so that got trained. This is Jackie, Jackie Bickham, who is the head of the Black Women in Prep Task Force. And so she is a wonderful partner of ours who I hope I partner with until I retire. And this is Meredith Clement that I mentioned before, and Winnie Erie, who's also helped us design our work. And then this just shows you what our campaign looks like. So we have 1 month starts about, prep is an option for women too. Then we have a whole month that talks about taking care of my health gives me peace of mind. We have a whole month about talking to your provider about PrEP, and then a whole month with, this isn't actually from it, but a whole month about I take PrEP for my family. And these are the main 4 things that came out of our formative work, so we focus on all of those. So any questions about, and here's our logo, Start the Conversation Project.
Yeah, I do have a question.
Yeah?
Okay, so the first one is do you integrate the community program to the normal standard of care for people who are living with HIV, or is it like a different?
So we're trying to make this as pragmatic as possible. And so the OBGYN residents, and it's hard. So, I mean, we train OBGYN residents on how to do this. So how to start the conversation about PrEP with their patients. And then we let them go to see if they do it or not. And so it's pragmatic, and they have to figure out how to work that into everything else they have to do with their patients. And some people don't want to do it because they don't think PrEP is as important as something else they have to do, or they have to talk about all these things. And so it's pragmatic in terms of, will people do it or will they not? What are the barriers that they face in the real world versus an intervention that you're studying out with people who you're paying to actually deliver an intervention? It's not like that. It's in the real world. That's how you're going to get the best data in terms of all the barriers that people face. No.
Okay. Then I have a, how did you measure the impact of the intervention on people that are living with HIV?
So none of these people have HIV. They're all HIV negative. So PrEP is something you take to keep you from getting HIV. But that's a good question, which I should probably add. So all the, well, for the OBGYN component, so the resident component, we look at their medical charts. And so we created these doc phrases. So after every, when you go see a doctor, they write notes afterwards. And so we have these notes where they click here, these smart notes. What they're called, but where you enter, did I talk to somebody about PrEP today, and then what's the outcome of that? So we record that, and then we can get that information, and then we review their chart notes. For the social media campaign, all the campaigns have a logo or a QR code that takes them to the state of Louisiana. They have a teleprep program, a really lovely webpage that takes them directly to the webpage, and then it tells them all about how to get on PrEP in New Orleans. Here's the providers you can use. You can call us, we can talk to you, we can call you, and then we're in partnerships with them, and so they collect extra data for us. They send us the data at the end of each month, and so we know how many people see the campaign that actually go to that site and then initiate PrEP. Yeah. Yeah.
Is this consenting research?
No. So the only things that people consent to, and they don't have to because PrEP is a standard of care drug. So they don't need to consent, and we don't get any identifiers. So when women see the campaign, they go to this website, they start PrEP. We just know that a woman aged whatever, and here's her race and gender, here's her race, here's her age, here's where she went. We know that. We don't know her name at all. So there's no violation of privacy or confidentiality. We just get this aggregated data. And same for the medical records. We just find out, we just check how many patients we're talked to. We do have some consenting documents where we will do formal interviews with patients and formal interviews with the providers, and that's consented because that is truly a research activity where these one-on-one interviews. So the other information, because it's pragmatic research and because we have no identifiers attached to it, it does not need to get consent. Which is good because it'd be really hard to get consent, and then it wouldn't be real.
So do you anticipate that there would be any differences between Tulane and California? Just
well, we hope so. I mean, at the time,
if you weren't doing the intervention.
Oh, if we weren't doing the intervention, at the time we started, neither of them were doing anything PrEP related, and so we would assume they'd be very similar in terms of nobody was doing it actually. Nobody was doing it. And so now once we started doing that at LSU, we do, it has upticked. It's hard, people don't just automatically do things right when you say you should do them. And even if they think it's important, they have 5 million things to do. So we do see an uptick. We have now also trained Tulane actually to do this as well. And so we're going to have multiple layers in that we can look at and see how uptake is good or how good uptake is. And the other thing is residency programs differ. And so Tulane's residency program is different than LSU's residency program, and maybe there's a residency program that's more apt to do this versus another one. So there's a lot of considerations with pragmatic research. Pretty fascinating, but a lot of things to consider. And it's not, you don't get the numbers that you get when you do an intervention that's in a vacuum, so to speak, where you have your, bring your people in, and like I'm coming up here to deliver an intervention, and we do a post test, and then you leave. It's not like that, so, but it's very useful.
Then finally, are you targeting the Black women because one of your community partners is Black, or is there a specific reason why you always target Black women?
So we're focusing on Black women because the rates of HIV transmission in New Orleans, Black women are really, really high. And it's just because the environment, mostly systemic racism, that's playing a role in terms of making it harder for women to be able to get care, making it harder for women to practice HIV prevention. So they are acknowledged as a group where there needs to be some sort of intervention. Now, our social media campaign really does focus on Black women because of our data that showed Black women don't know other women, Black women taking PrEP. We wanted that to be very clear. For the OBGYN residents, they have to offer it to everybody because PrEP can benefit anybody who's having sex. So they don't focus only on Black women. We'll know that, we'll get the data in terms of gender, race from them and ethnicity. But they offer it to anybody who they feel needs it. But the campaign focuses specifically on Black women. Yep.
Are you keeping track of if the clinician brings it up or if the patient brings it up, or is that more what you're doing with the phases where you're comparing like the social media?
Yeah, it's mostly in the phases, but when we do the interviews, we ask about that at the end. How often is it where that you bring it up versus that the client brings it up? Specifically, that first phase is really the provider, not the provider's role is to bring it up, but we'll see the patients bring it up more, but we'll find that out in the interview. That's the only way that we can find that out.
Okay.
Yeah. Okay. All right. Let me go to my next example. So this one is called Locaparo. It stands for very long. This is the little word, and it means transforming attitude. The very long one, this is the nickname for it. I won't be able to say the long one. But this is an R01 grant. It's a developmental R01 grant, which is we're designing an ethnodrama intervention. It's focusing on reducing community-wide stigma towards young women in Kenya. So earlier we talked about partners. Here's all the partners that we have on this team. So Kawango got up here in this corner by the lake. So this is a woman. She is a social scientist like me. She has a very large research organization in Kisumu. I've been working with her for almost 20 years. We just keep doing research over and over together. So we were on the original PrEP trials, clinical trials, back in the day, and then since then we just do a lot of different studies to try to look at how we can improve PrEP uptake among young women in Kenya. So we've been together this is our same grant. We've been together for a while. And then you have working. This is CJ Adongo. So he's a new partner to us. So for this grant, we wanted, and I'll get into this a little bit, but Kwame and I did some research. We did an R21. We did photo voice where people go and take pictures of things that talk about what helps them to take PrEP, what hurts them to take PrEP. It's a big study. And then from that, we learned that community stigma is really big. And we talked about maybe drama could be a way to address that. Drama is very locally accepted. It's been embedded in African culture forever. Maybe that's a way to be able to help community stigma. Community level interventions are really, really hard to do. Everyone, but drama is a good way to do that. So what we did is we reached out to drama folks. So CJ is an academic at a university in Eldoret, at Moy University in Eldoret. And then he leads this group called the Eldoret Film Festival, where he has all these folks, they just do a ton of film type work. So he became a partner with us. And we have Michael Relf, who's a stigma expert here. And then we also reached out to Lynn Dickerson. So Lynn Dickerson is somebody here in Durham who owns a drama group that focuses on social change. So everything about this is drama for social change. It's theater of the oppressed. And so this is what this group is trying to do, is to create these ethnodramas, use the data that we have, create these plays, and then we'll test it out to see if that actually reduces stigma towards young women. So this shows you, this is the previous work that Kwame and I did. These are photos that participants took. We had 5 or 6 participant groups that this was a 2-year study. Y'all haven't heard about photo boys. You basically give people cameras, you give them a topic, they go out and take pictures of it, and then they come back and talk about it in a group. And so we had them go take, we'd have women who were on prep do this, male partners of young women, female peers of young women, family members, formal leaders, healthcare providers. They all were getting 80 cameras at one time to Kenya. They all went out and took pictures, basically of things that help women to take PrEP, and then things that were barriers to them taking PrEP, in a nutshell. And we learned that misperceptions about PrEP is really, really common. And its stigma is that among young women taking PrEP is fueled by those rumors and gossip from people, all those people we just talked about. And young women in sub-Saharan Africa are probably the group, and they are the group, that is at greater risk for HIV in the whole world. They get HIV more than anybody else in the whole world. And stigma is a major reason that they don't start taking PrEP. So we really wanted to do something and stigma is huge, so we can reduce that at the community level. So we took all this data, and then we wanted to create an intervention, which our long-term goal is to create an environment. Our idea is that there's a lot of interventions out there that people do to try to help people take PrEP. Adherence interventions or couple counseling, but all those things aren't going to work if they're in an environment that's not supportive of young women taking PrEP. If they're in an environment that's still stigmatizing, none of these other interventions are going to work. So our idea is that interventions will be more successful when they are embedded in a supportive environment. So you have these social norms that encourage young women to take PrEP, and they normalize it. You expect young women to take PrEP versus then stigmatizing women who want to use PrEP or who are taking PrEP. So this is our long-term aspiration. And so this is what our developmental RO1 is doing. And so we are developing, pre-test, and piloting community-level ethnodrama interventions designed to transform community members' beliefs about and sponsor support of young women PrEP use. And it's really pretty basic. One thing about writing grants, sometimes the more basic of your specific aims, you might get them funded. Look how simple these aims are. This one's funded. Sometimes I write aims, I think they are elegant and lovely, they're too complicated, and they don't get funded versus simple ones get funded. I can give you example after example. So year 1, we spent a whole year, we just finished that, developing the intervention, and I'll talk to you about that. Year 2, we're pre-testing the intervention. We're doing that in a controlled environment. We're inviting people in from those 6 groups that I mentioned that we did with the photo voice research, and having them watch these ethnodramas that we've created and tell us what they think about them. What do they like about them? What do they not like about them? To be really sure that we are not perpetuating stigma. It's very interesting to do an ethnodrama where you have to talk about the stigma so people know what you're talking about, but at the same time not go too far to further stigmatize it, further stigmatize women, or further stigmatize people with HIV. There's a lot of discussion on that. And then year 3 is when we're going to pilot it for real in a community where we'll just go out to the community, start doing these dramas, and see who's. So I'll talk to you about the different steps. So during year 1, we had a week-long workshop in Kenya where we talked all about the science of HIV research, all about the science of trauma. So we talked about social norms and the types of stigma. We talked about the theory that we use in terms of storytelling and narrative theory and the things that come with that in terms of you have to create a play that people can identify with, characters, the storylines are real, and if you have that, then it transforms people, it transports them into this world where they can actually change their attitudes. And then we talked about the theories of drama, in terms of theater of the oppressed, and that is where you have this interactive theory for acting out solutions to certain problems, right? And then you're hoping to solve those social problems. And so what we did at that workshop, we identified 6 types of scripts, basically 6 plays that are about 15 minutes each, that are going to try to address these things that we learned from our R21 data. So each one focuses on the drivers of PrEP stigma. So there's something in there that talks about gender and sexuality norms. Each play focuses on a different level of influence. It could be peers that are giving women a hard time. It could be their partners. It could be a family member. Or religion is one. Each one deals with some sort of stigma. Most of it is enacted stigma, which means people in the community are actually giving stigma, perpetuating somebody else with that stigma. Everyone has some sort of that they go through in terms of they start off with the status quo in terms of the current stigma. Then you get to some sort of conflict where somebody's wanting to support women, somebody's not, with this big conflict that everything blows up, and then they all get resolved and they come back to this new normal. And through that, you're trying to ensure that you have these characters that are very relatable and that you have these scenarios that you can relate to. We spent about 8 months or so. We started off with this workshop, and then we probably only spent like 6 months developing these scripts. We did have a community advisory board that we met with a couple times where they would review the scripts, give us feedback. And then now what we're doing is I just got back Friday is we're going to pre-test these scripts for acceptability. We're going to do these 2 rounds of pre-testing. And this is a controlled environment. It's private. We purposely select the people. These are the 6 groups that I mentioned. And the whole point of that is to find out, are they things acceptable or not? Do you find these storylines real? Do you find the characters identifiable? Relate to them? Do you see them? Is it making you think about things differently? Are we starting to transform your ideas? So this is what we're going to do really for the next year. So it takes 12 weeks to be able to pre-test each one of these skits. We bring these people in. We can't all come at one time, obviously. Do surveys with them afterwards, do group assessments with them afterwards, find out what they like, they don't like, and then we change it. We'll do 1 more round of pre-testing next year, and then we will launch that in June of next year for the piloting. And that's what I mentioned, where we'll go for real into the community and start doing these things and see what people do. So how we'll measure that, again, it's just a pilot, but we'll have these 3 cohorts. We'll have a young women's cohort, which we'll purposely invite, and they'll come to all the different performances, and we will, and so we're not to identify some of this stuff. We'll have them, we'll measure their perceptions about heart stigma during the pilot, at the end of all 5 performances. This is 5, but there's like 6 performances, and then 3 months ago. So this is the gauge how women feel, so they feel like the stigma is getting reduced at the community level. We'll also have a community member cohort who they will come to the different performances and we'll measure things in terms of the theory. Are they getting transported? Do they find these things relatable? And then we'll do surveys with 100 audience members along the way to be able to find out what they think about the place and are they having some type of impact with them. So here's our science design right here. And then we'll also, as with any type of pilot, acceptability and feasibility are what we usually are looking at in the pilot, sometimes preliminary effectiveness, which we're looking at as well. You really want to look at implementation feasibility. So there's a lot of measures that we look at. How easy is it really to go out there and do these dramas? Are people showing up? Are they seen at the end? Are they laughing? Are they whistle up? Are they engaged? So we're going to collect all that type of feasibility data as well. And so these are pictures from our training last week. And this is all this practice where we did bring in the community advisory board again and then other staff to be able to watch the team's practice. So there's several different parts of these plays that they do to really lead to social change. And that's what's different. This is interactive, theater-based threats made for social change. It's different than like if we go to a play and sit in the audience, the actors come out, they leave, we don't engage with them, then we get up and go at the end. This is really, really different. So what they do here, at the beginning of the play, actors here come out. So they're behind the scenes and they come out either yelling something or what it might be, or singing. They're trying to get everybody's attention, trying to mobilize, trying to get people to come watch it. And so on the left, this fellow here is pretending to do something, that he's gathering people to come watch. On the right, they're singing a song. So it's a really loud way to bring people in, to have them watch the play. Here is what the different scenes look like in terms of the different stigmatizing situations that they have going on here. In the left-hand corner, this is about they're having a storyline of salons. Salons are a really big place for gossip to happen, so they're having a salon story here. And the upper left-hand corner, this is a whole one about pastors. Church influence is a big deal in Kenya, and there's a lot of rumors that happen from pastors. This is the pastor who changes his mind. The one on the blue shirt and the gray shirt, they're talking about a important couple and how they should be using prep. So each one is focusing just on a different topic of those 6 that shows you what this place looks like. And then what social change theory does is they engage the audience during the performance. So as you can see, the actors are going into the audience and handing them things or asking them things, like the lower column is the man standing up. On the left, he's asking the people in the audience questions. He's engaging them. Well, shouldn't I be mad at my question? Don't you think? Or, and asking them questions to get them to be engaged and pay attention. And then at the end of the play, after it's all done, they clap, and thank you, and then the actors come back out and engage in a dialogue with the audience. And this is when you're really trying to have that discussion in terms of, what did you see up here? How did it make you feel? And have these questions specifically to ask about stigma. So when everybody leaves, the idea is they go with a better understanding of how harmful stigma can be, and they leave really again with wanting not to stigmatize women for taking breath. Okay. What questions do you have there about that? Yeah.
Well, I'm just curious, is there like a method of making an movement to like the whole city about the ethno drama program, or how do you get people to be aware of it so that you gather them together to watch?
Right. So for the pre-test, we will mobilize people like you normally do to gather people for interviews. So we'll go to, so there's a team called mobilizers, and they'll go to women's groups and to the different places where they normally recruit for research activities. That is a controlled environment. When we do it for real, you are just going to show up in a marketplace, and then you're going to do the actors do the mobilizing, where they're going around and singing and making a rocket show, and then bringing people to go watch the play. And this is what the art, really what Theater of the Oppressed does. So that's what they're very skilled at. So we have not done that yet. Right now we're just in a controlled environment, but that's really what it's going to be. Does that work? Are people going to come and listen to this 15-minute play, or are they going to leave? So that's going to be an interesting question. And one thing that when we go back next year for training, a lot of the training will focus on that. What are the skills you do to actually get people to say, oh, let's go follow this guy versus this person who's just saying we don't know what he's speaking about.
Then I have about your choice of sampling. You said that there was one of the slides where you talked about after the your audience members. Yeah. So what's your method of sampling that particular number?
Yeah, so that one is we have a mass audience. We want to be able to randomize people, but people aren't going to wait or try to do some sort of systematic sampling. And so what we're going to do is we have multiple research assistants. We use a method there's something called the place method, where they have come up with a way that's acceptable in order to identify people in situations like this, where you basically identify what's the middle part, and then you just, the RAs, not randomly, but they're like, okay, here's 5 people down, here's 5 people down, here's 5 people down, and then you go and you find those people and interview them. And so it's a method that provides some sort of structure for finding people, when you can't really just go around and say every other one will interview, because people aren't like that. So we've just done it for another survey in Kenya. The place method is a method that's been going on. We started it 20 years ago or something, and it's fine-tuned, and it's the best you can do in that type of situation. Yeah.
Can you evaluate the effectiveness?
So right now, it's the pilot. We're only asking people, the main way we'll evaluate preliminary effectiveness, we don't have the sample size to do pilot in small funds. We'll ask women that we get baseline data before they see any of the play, the end of the play, and then after that, 3 months after, depressed stigma scale. And so it's a validated scale in terms of how they feel about stigma. They're seeing or feeling the community. And do we see change over time? Now, and we'll, in if we get funded to do the real thing, so this is a developmental R1, we want to be able to get the 5-year real R1 where we do have to have effectiveness and have the sample size. We will have much larger samples of women, and we'll still do that stigma scale. We're in the process of writing a grant to validate a critical consciousness scale that we would actually, then we would use that with audience members and
did this transform you? And we would have enough data to express it or not. And then we would have adherence data as well in terms of women on drugs.
Most of these women getting, they're high risk because of stuff. Is there an equal, is there another push to get, like, say, men on?
I mean, there's most of the work in Sub-Saharan Africa focuses a lot on women because they're the ones that are at greater risk and is trying to be able to empower women to be able to take charge of their own health. Clearly, if anybody who has HIV, if they're able to get on treatment, stay on treatment, then their viral load can be undetected and they can't transmit. Because then you're relying on somebody else in order to protect yourself. And so we focus on everybody, and men too, but the programs are on women. Although that's one of our plays is talking about a man wanting to use PrEP too. We want to be able to show that anybody can use. It's a good idea for anyone who's sexually active who thinks they could be exposed to, but mostly focus on men, women and men. In the U.S., though, a lot of things focus on gay men. There's more and more going for cisgender women, but gay men have been a primary focus in the U.S. They're different depending on the location. Any other questions? All right. That was it.
So, Amy, thank you again for coming. And you know, so let the class know that every time I hear Amy's research, it sort of blows my mind because this is not what I think HIV research should look like. In my mind, it's a very discrete. So what do we do HIV? We work in the lab, we play test tubes, we do some number crunching with our base statistics. Not going out to the market and doing drama and dance. And so it's like, I think it's very inspiring and sort of extends the idea of what research in HIV is like. And also it's inspiring in that if you have a talent or interest in like dramatic or performing art, there is a role you can put your skills to use in research as well. So I think it's just amazing.
I mean, I think the big take-home message is creativity. I mean, everything doesn't have to look the same. And I'll tell you, it is far more fun to do things that are outside the box and to work with people who are passionate and experts in their field and seeing how that overlaps. So especially this grant, when I keep talking about the science of theater, they don't call it that, but I see the science in their work. Like they're very methodical in how they design scripts and how they perform scripts, and they are just as meticulous in that as we are in science. And that's why it's this really cool partnership. And it's just, the community partners, I don't think I can stress enough about how it enhances the work that you do. It gets, you're in a field for a really long time, your career is how long? To have these community partnerships just make it more enjoyable, and the work that you do ideally is better because there's just more people that know what's going on in the field are contributing to it. So it's a lot of fun to do this type of work.
Yeah. We had Lizzie and community member Eugenia speak to us during orientation. Have you worked with the D3C and your project?
I haven't. So the DC3 evolved before, after, sorry. These projects all came beforehand. But, I actually asked the DC3 this recently because we haven't worked with them. And I haven't worked with them because I have all these community partners. All my projects, I've always had community partners. I don't know how to do research without community partners. So it's always something that's embedded into the work. And so they're always where they're from. And so I do work in Durham, but I have a community partner in Durham. But I did ask them, I was like, I don't ever come to you because I have these other community partners. What do you think? And they're like, that's fine because you have community partners. They're really for people who that's not part of their model that don't already have community partners to reach out to the DC3. Yeah. Great. All right. Well, thanks for having me.